Bismillahirrahmanirrahim. Quote of the day is: "The wound is the place where the light enters you." This is the quote by Rumi. My name is Dr. Aamna Khalid, and I will be presenting the topic of tuberculosis under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health. These are the learning objectives of today's presentation. We will go through the introduction of the disease, the epidemiological determinants, clinical features and complications, diagnosis, prevention, control measures, global and national burden, recent advances, and then the practice of MCQs. Tuberculosis is actually a chronic communicable disease caused by the mycobacterium tuberculosis. It mainly affects the lungs, but can also involve other organs. It's suppressed by the airborne droplets. It's a major public health problem, and it is preventable and curable with timely treatment. The dynamics of disease includes the reservoir, that's the mainly humans, and the mode of transmission is airborne transmission via the inhalation of droplet nuclei, ranging from 1 to 5 micrometer. These are produced by coughing, sneezing, speaking, or singing. The incubation period of the disease is 2 to 12 weeks, and the communicability is during the active TB disease, typically during coughing. TB can be of two forms, the latent TB and active TB. Latent TB is without any symptoms, and active TB is symptomatic and it is contagious. It can be converted, the latent TB can be converted into the active disease when there is weakened immune system. The epidemiological triad of the TB will include the agent, host, and environmental factor. We will discuss them one by one. The agent factor, as discussed, is the agent is Mycobacterium. It is an acid-fast aerobic bacillus. It's a slow-growing organism. It's resistant to drying and weak disinfectants. It's killed by heat, sunlight, and UV rays. Its a high lipid content of cell wall renders its high virulence, and it can remain dormant in host for years. These are the host factors which include low immunity, as in case of HIV infections or malnutrition, extremes of ages like children and elderly, overcrowding and close contacts, comorbidities like diabetes and pneumoconiosis, smoking and alcohol use. Environmental factors include overcrowded living conditions, poor ventilation and indoor air pollution, poverty and low socioeconomic status, poor housing and sanitation, limited access to healthcare services, migration and urban slums. And these are some major clinical features of the disease that includes persistent cough for more than 2 weeks. It's often productive, but sometimes hemoptysis is also there. Then we have fever, which is often low grade, night sweats, weight loss, and anorexia. Due to coughing, there can be chest pain, or called the pleuritic pain, fatigue, and malaise. Lymphadenopathy are local symptoms for extrapulmonary TB. Not only being a clinician, but also being a public health expert, we still know different classifications of tuberculosis so that we can intervene accordingly. First of all, we can classify tuberculosis on the basis of the site of disease. It can be classified into the pulmonary or the extrapulmonary. The extrapulmonary involvement can be in the lymph nodes, pleural TB, TB meningitis, bone and joint TB, genitourinary TB, abdominal TB, pericardial TB. According to the activity of the disease, it can be classified into the latent and active TB. Active TB is symptomatic and it's microbiologically or clinically confirmed. And latent TB is asymptomatic with no radiological evidence, but IGRA test is positive. We will discuss it later. Then we can classify TB on the basis of the sputum status. Either it is mere positive TB with AFB positive on sputum microscopy, or it's mere negative TB with AFB negative but clinically or radiologically suggestive. Then on the basis of the patient's history, TB can be classified into a new case where patient has never been treated or has received less than 1 month of anti-TB drugs, or it can be a relapse. Patient had successful treatment, but now TB again returned, or it can be treatment failure because the patient's previous treatment was unsuccessful, or treatment after loss to follow up because patient stopped the treatment and is now resuming it. On the basis of the resistance to the anti-tuberculous drugs, it can be classified into the drug-sensitive TB, poly-resistant TB, extensively drug-resistant TB, mono-resistant TB, and multi-drug resistant TB. We will define them later on. According to the severity and spread of the disease, it can be classified into the primary TB, where the initial infection in the previously unexposed individual is there. In the post-primary TB, reactivation of the latent infection occurs. Sorry. Okay, on in the miliary TB, there are tiny lesions spread throughout the body, and in disseminated TB, widespread infection affects the multiple organs. So these are the complications of untreated or inadequately treated TB. First of all, there are complications involving the lungs, including bronchiectasis, cavitation, pleural effusion, massive hemoptysis, chronic respiratory failure. If pleura is involved, there can be empyema or fibrothorax. In case of dissemination, it can be presented as miliary TB, tuberculous meningitis with a neurological sequelae, Pott's disease involving the spinal deformity or paraplegia. Even there can be treatment-related complications due to the drug toxicity, including hepatic peripheral neuropathy and myelosuppression. Along with the clinical diagnosis, as the clinical symptoms are already discussed previously, now we come to the laboratory diagnosis of TB. The microbiological tests include sputum culture, which is the gold standard, and it takes 2 to 8 weeks, and it enables drug susceptibility testing as well. Then we have gene expert, which detects the bacterial DNA, and it identifies rifampicin resistance, and the result comes in around 2 hours, and it's recommended initial diagnostic test by WHO. Then we have sputum smear microscopy done by ZN staining. It detects the acid fast bacilli. I'm so sorry. It's rapid and inexpensive, and but the sensitivity is limited, especially in case of HIV and extrapulmonary TB. Then we have chest X-ray, which shows the findings of upper lobe infiltration, cavitation, fibrosis, or pleural effusion. In case of histopathological diagnosis, we can go for a tissue biopsy, which shows caseating granulomas or Langerhans giant cells, and it's useful in extrapulmonary TB. Then the immunological test, which involves tuberculin skin test called Mantox test, which indicates tuberculous infection but not the active disease, and its specificity is also limited. Then is the interferon gamma release assays IGRA, which detects the latent TB. Then some additional supportive tests include the ESR, which is raised anemia of chronic disease. Pleural fluid analysis, which shows lymphocyte predominant exudate and high ADA. In case of tuberculous meningitis, we can go for CSF analysis. Treatment of TB. Treatment of TB involves multi-drug therapy. We can adopt the strategy of directly observed therapy, that's DOTS, and then we will see the treatment of drug-resistant TB. First of all, we will go through a new case management. The treatment goes for 6 months, and the first 2 months are called the intensive phase, in which we have to give 4 drugs, including isoniazid, rifampicin, pyrazinamide, and ethambutol. Then in the next 4 months, which is the continuation phase, we have to give only 2 drugs, that's isoniazid and rifampicin. These should be given as daily fixed dose combinations. If we have a previously treated tuberculosis case, then we have to go for drug susceptibility test, or treatment should be based on that. We should avoid the empirical retreatment and individualized regimen if resistance is detected. In case of extra pulmonary TB, the same regimen is applied as the pulmonary TB, but the duration is extended for 9 to 12 months. And this is done in case of tuberculosis meningitis and spinal TB, that's also called POTS disease. If there is a multi-drug resistance MDR-TB, which is resistant to at least one group, including the isoniazid rifampicin, then it's labeled MDR-TB. So we prefer the second line because it can be isolated and cyclosidine, oxytocin, etc. In case of extensively drug-resistant TB, XDR-TB, which is resistant to to all the groups except one, it means it is actually MDR-TB plus resistant to fluoroquinolones and or the second line injectables as well. So in this case, we have to use the newer drugs, including linezolid, and its management is done at specialized DRTB centers. If we have a TB HIV co-infection, we have to start the anti-tuberculosis treatment first, and we have to initiate the ART treatment within 2 to 8 weeks afterwards. 4 trimesters of prophylaxis should also be given. In case of the tuberculosis in pregnancy, the routine treatment of isoniazid, rifampicin, all that is safe. And we should avoid streptomycin, and BCG should be given to the newborn after birth. If a patient during lactation has TB, TB is not a contraindication to breastfeeding, and ATT is safe during lactation, and a main transmission risk is still the droplet infection, not the milk. So infant needs screening and preventive therapy as well. Directly observed therapy DORS involves the patient empowerment to ensure the adherence to treatment. And there is reduction of the risk of drug resistance. So the patient outcome is improved, and community involvement is there to promote collaboration and accountability. Uh, for contacts, we can give TB preventive therapy, TPT, and the purpose is to prevent the latent TB infection from progressing to the active infection. In children less than 5 years exposed to the infectious tuberculosis or HIV and other high-risk contacts should be treated prophylactically. But before TPT, we should exclude active TB because in case of active TB, we cannot give TPT. The recommended regime is isoniazid for 6 to 9 months, and rifampicin-based shorter regimes are also there. I will tell you in this, yeah, right. Isoniazid preventive therapy (IPT). In this regime, we can go for the isoniazid daily for 6 months, and some guidelines also tell that it should be extended for 9 months. Then we also have rifampicin-based shorter regimes, which can be 3HR, means isoniazid and rifampicin for 3 months. Then we have 4R, means rifampicin alone for 4 months, or we have 3HP, which means for 3 months we have to give isoniazid and rifampicin weekly. This is weekly. All right. Then, in case of TB and HIV co-infection, the people living with HIV are 12 times more likely to fall ill with TB disease than people without HIV. And in 2024, as per the data of WHO, about 150,000 people died of HIV-associated TB. The percentage of people who fell ill with TB and had a documented HIV test was 82% in 2024. Globally, in 2024, only 61% of the estimated number of people living with HIV who developed TB received antiretroviral therapy. The collaborative activities for both the diseases can reduce morbidity and mortality from HIV-associated tuberculosis, and it includes actually bidirectional screening, prevention, and treatment of infection and disease. And the scale-up of TB treatment and ART since 2025 by WHO is estimated to have averted 9.8 million deaths. The global burden, as per the data of WHO, a total of 1.23 million people died from tuberculosis in 2024. And globally, TB is the world's leading cause of death from a single infectious agent, and it's among the top 10 causes of death. In 2024, Around 10.7 million people fell ill with TB worldwide, including 5.8 million men, 3.7 million women, and 1.2 million children. In case of drug-resistant TB, it has been the leading killer of people with HIV in 2024 and major cause of death related to antimicrobial resistance. Global efforts to combat TB have saved an estimated 83 million lives since the year 2000. Okay, this is the data from 2023, which shows different age groups affected by the TB. And you can see that the incidence rate is highest in the age group of 55 to 64 years. And under 5 children are also highly affected. This is the rate of new tuberculosis cases again in 2023, and you can see that Pakistan is in the color which shows the range of 200 to 500 cases, and as per the data of 2023, 277 cases per 1 lakh people were reported. This is the MDR-TB cases data, and you can see that the graph, once it showed a decrease around in 2015, but again it's rising, and till 2021, the prevalence of MDR-TB was around 6.5 lakh, and the incidence was around 4.5 lakh. These are the number of deaths from TB. The data is from 2021, and you can see that the darkest shade is shown by in the India. There is highest mortality from TB, and in Pakistan we had 65,000 cases in 2021. So this highly prevalent disease has to be prevented, and the level of preventions are primary, secondary, and tertiary. For primary prevention, we can go for the BCG vaccination at birth. We should give health education regarding the cough etiquette and respiratory hygiene, early health seeking behavior. Improvement of living conditions should be there, adequate housing and ventilation, reduction of the overcrowding, improved nutrition to enhance immunity, infection control measures for the use of mask in the high-risk settings, and proper ventilation in healthcare facilities. And then we have to address the social determinants, including poverty alleviation and occupational safeties. BCG vaccination, as discussed, is a primary prevention. It reduces TB severity, meningitis, and miliary TB. It's given at birth. 0.05 ml is the dose. It's not a cure. Its efficacy is 60 to 80%. The route is intradermal, and it's given in the left upper arm. Secondary prevention involves the early case detection, also both the passive case finding when the symptomatic patient comes to the healthcare facilities, and the active case finding in the high risk groups. Then we have to do this clinic of contacts of TB patients. Lab diagnosis should be done. Prompt initiation of the anti-tuberculosis treatment under national guidelines should be there. DOT should be applied to ensure adherence, and surveillance and notification of TB cases. The tertiary prevention involves the complete and supervised treatment to prevent relapse and drug resistance. Complications should be managed. Drug-resistant TB should be treated. Nutritional support should be done. Psychosocial support and counseling is needed. Rehabilitation, follow-up, and monitoring for relapse. This is the policy dialogue on the prevention of tuberculosis that occurred in IPH Lahore in our institute. So the World Tuberculosis Day is celebrated for the awareness purpose on 24th March of every year. Now we come to the recent updates. Okay. WHO has a strategy. The end TB strategy goal is set for 2035 to reduce TB deaths by 95%. Universal access to prevention, diagnosis, and treatment, and innovation tools and technologies. These are the three main pillars of this strategies. The pillar one is integrated patient-centered TB care and prevention. Pillar two is bold policies and supportive systems. Pillar three is intensified research and innovation. And all of these pillars are based on the government stewardship and accountability with monitoring and evaluation, building a strong coalition with civil society and communities, protecting and promoting human rights, ethics, and equity, adaptation of the strategy and targets at country level with global collaboration. Then we have the provincial TB strategic plan set for 2024 to 2026. The focus is on the prevention to expand the BCG vaccination, on the diagnosis, to give improved access to rapid tests, and on the treatment to ensure adherence to the dot or the treatment, and then the management addressing social determinants of health. All right. These are the targets set by the NTB program. That they plan to reduce the number of the TB deaths by 95%, reduction in TB incidence rate by 90%, and TB affected families facing catastrophic cost due to TB 0%. Right. Even the SDG goals set for 2030 are also mentioned. And these are the milestones we have achieved in 2025. Reduction in number of TB deaths are 75%, not 95. We have 10 years more to achieve this. And then reduction in TB incidence rate is 50%, and so on. All right. Then this is our national TB control program run by the our government under primary and secondary healthcare. The key focus areas, as I have already mentioned, diagnosis, treatment, and prevention, and also the capacity building and advocacy, data surveillance, and monitoring. The key achievements are to get the treatment success rate for more than 94%, and screening of around 8 lakh people were done in 2021, and free treatment for TB and drug resistant TB cases was available according to them. So this is again almost a repetition of the same thing, the provincial TB control program. This is the important thing, that components of our TB control program are the diagnosis, treatment, active case finding, TB HIV co-infection, HIV screening of the registered TB cases at all TB management units, then the public-private mix involving the GP clinics, NGO-run hospitals, private hospitals, and parastatal hospitals. And advocacy should be done by the print, electronic, and social media campaigns. Now we come to the recent advances in the diagnosis and treatment of the tuberculosis. So by application of the artificial intelligence in the diagnosis of pulmonary tuberculosis, we can improve the diagnostic accuracy, sensitivity of the chest X-ray and CT-based test. We also have sensitive diagnosis of possible bacillary tuberculosis with targeted next generation sequencing. It is the molecular diagnostic studies, and the conclusions shows that uh, um, uh, the next generation sequencing is a potentially promising test that enables rapid and sensitive diagnosis of TB in children and individuals with extrapulmonary TB. Whole genome sequencing based a surveillance system for Mycobacterium tuberculosis was done in Portugal, and this study underscores the diverse TB epidemiology in Portugal, and they highlighted the importance of sustained prospective genomic surveillance with improved data integration and centralized reporting to strengthen the national TB control efforts. Okay, then modern digital technologies for for monitoring tuberculosis adherence. A different type of technologies have been introduced, and they have shown promise in improving treatment outcomes and medication adherence. Digital adherence technologies are increasingly being used now in the TB management for the to follow the adherence. Now we come to the practice
Mhm.
of MCQs. The first question is
I'm
the
sure.
first question. The first question is a 35-year-old woman living in a densely populated urban area reports intermittent fever, night sweats, and significant weight loss. Putum smear microscopy is positive for acid-fast bacilli. Which public health measure is the most immediate priority to prevent the spread of the TB in her household? Option A, administering BCG vaccine to her children. Option B is initiating DOT for the patient. Option C, conducting community-wide health education. D, providing prophylactic antibiotics to household contacts. And E, improving the nutritional status of health, family members.
D.
Option B is the correct one. We have to initiate the treatment under DOTS. Then we have question number two. A 60-year-old man with a latent tuberculosis infection becomes immunocompromised uh, immuno after starting chemotherapy for cancer, which is the most likely outcome if latent TB remains untreated. Development of pulmonary fibrosis, progression to active disease, complete spontaneous resolution, chronic bronchitis with recurrent infections, or pneumothorax due to cavitary lesions.
B.
B.
Yes, yes, B is the right option. Um, Question number three is a TB control officer is evaluating the effectiveness of recent interventions in the rural community. The program's main goal is to prevent transmission. Which intervention directly targets the mode of transmission for Mycobacterium tuberculosis? Option A, nutritional supplementation for malnourished children. Then a routine vaccination with BCG, installing ventilation systems in the overcrowded areas, monthly health checkups for early diagnosis, or mass screening with chest X-rays.
E.
C is the right option for the rural community. Option Question number four: a public health worker conducts contact tracing for a confirmed pulmonary TB patient. Which factor increases the risk of TB transmission to household contacts? Option A: use of oral medications by the index case. Poor adherence to treatment by the patient. The patient's history of BCG vaccination. Absence of drug resistance in the TB strain. Diagnosis of latent TB in the patient.
B.
Yes, poor adherence.
E.
Question number five: a newborn in a TB endemic country receives a BCG vaccine. With what is the primary benefit of this vaccination? Preventing all forms of TB, providing lifelong immunity, reducing the severity of TB meningitis and malaria TB, preventing latent TB infection, and eliminating TB transmission risk.
B.
No, it's C, reducing the severity of disease. Question number six: a national health policy team is a making the strategy to achieve the NTB strategy targets within the TB burden country. While reviewing interventions, they noticed limited success despite widespread use of conventional diagnostic tools and a modern treatment success rate. Which integrated approach would most effectively align with both the global target of reducing TB by 95% and improving TB case detection rate? Option A, increasing annual vaccination campaigns, expanding the use of chest X-rays, implementing community-based screening programs, mandating hospital-based isolation, and developing new antibiotics for first-line treatment.
C.
C.
Yes, option C is the right answer. Question number seven: a recent initiative integrates AI technology for TB diagnosis. A smartphone-based tool analyzes the patient's cough sound to screen for TB. Which benefit does this innovation primarily offers? Increased sensitivity, faster or more accessible screening in low resource settings, complete replacement of traditional diagnostic tests, prevention of resistant TB, and enhanced vaccine coverage.
B.
Yes, B is the right answer. Question number eight. A 45-year-old man diagnosed with MD or TB has a history of incomplete prior treatment due to medication side effects and poor follow-up. He now presents with severe symptoms and extensive lung involvement. Considering global recommendations, which comprehensive strategy will best optimize his treatment outcome and prevent further drug resistance? Option A: intensifying isolation protocols and starting a second-line therapy, administering first-line antibiotics with adjusting the dose to reduce side effects, employing a patient-centered supervised multi-drug regime with psychosocial support, providing experimental third-line antibiotics without direct supervision, relying on periodic symptom-based adjustment to the medication regime.
A.
C.
Yes, C is the right answer. Question number nine. A mother brings her child to a clinic for cough evaluation. AI-based analysis of the cough suggests potential TB. What should be the next step? Start treatment immediately, perform a chest X-ray and sputum examination, prescribe antibiotics for pneumonia, recommend home rest and follow up in 2 weeks, initiate contact tracing before confirming diagnosis.
A.
Option B, we cannot completely rely on the artificial intelligence. Question number 10. A public health initiative focuses on rapid molecular tests for diagnosing TB. What advantage do these tests offer compared to traditional methods? Reduce TB duration, higher sensitivity in latent TB, faster results with drug-resistant identification, lower cost in sputum culture, complete prevention of TB transmission.
C.
Yes, a C, faster results. This is the key. This is the YouTube channel where this will be uploaded. Thank you.
Thank you so much, Dr. Aamna. It was a great presentation, but I think the time was short, and if the time had been longer, it would have been wonderful.